Thank you, Madam Chair, and good afternoon to you all. On behalf of the Ghana team, I present the story in Ghana, how we went about setting the agenda for newborn health, how we formulated our policy. I'll talk briefly about implementation of newborn activities in primary health facilities and in the communities. And then I'll talk about what we see as our enabling factors and our challenges. Ghana is situated in West Africa, surrounded by Francophone countries, but we are Anglophone. And we have a population of 24 million. The country is divided into 10 regions. Our GDP rate is, for 2012 was 8.2%. Total fertility rate is 4. Maternal mortality rate stands at 350. Our scale birth attendance is 59%, and neonatal mortality rate is 30 per 1,000 live births. Although our national figure for neonatal mortality rate is 30, as you can see from this slide, there are wide variations across the regions, with the highest being 47 in the central region and the lowest in the Upper East region. Interestingly, the lowest is in one of our most deprived regions, and we see their success as partly due to the wide community level activities that they have carried on for child health. In this slide, we see the trend for under 5 mortality, infant mortality, and neonatal mortality. And as is common with most countries, you can see the lowest, which is the blue line. That's the neonatal mortality trend since 1990 has really declined very little, although the other two have gone down quite a bit. And the major causes of newborn deaths are similar to other countries as well, with birth asphyxia ranging, being the highest, followed by neonatal sepsis and pre-birth or low birth weight babies. And this is from our 2010 EMONC survey. To set the agenda, the whole story started mainly in 2003 when we had our demographic and health survey report and realized, surprisingly, that we had made little progress in reducing our under 5 mortality. So we started looking at our figures more closely and realized that the rate determining step was the newborn deaths, where we had made very little progress. A child health task force team was set up to come up with a child health policy and strategy. And we looked at various sources of data, apart from the household demographic data that we had. We also looked at our own service delivery data. And we conducted a situation analysis of child health in the country, where we went across the country talking to key informants, looking at research available, and also looking at the various data sources. And then we also had an EMONC survey. And all these gave us the background data to direct the policy formulation. I must say that although there was a task team in place, there were wide consultations. It took us almost a year to finalize the child health policy, trying to get the views of all stakeholders and getting them involved in the formulation of the policy and the strategy. And that's a picture of the policy you see on the left. And it follows the continuum of care approach to improving child health. And it's widely endorsed by the Ministry of Health and its agencies and partners. In fact, it was launched at one of our highest, actually our highest decision-making forum, the Health Summit. And it's been widely disseminated, and all stakeholders are on board and see themselves as owning this document. Now to the implementation. We have in place a national child health coordinating body, and a subcommittee of it is the newborn committee, which looks specifically at newborn issues. And last year, we instituted an annual newborn stakeholders meeting. It's supposed to be held every year henceforth. And at that forum, all regions are represented, all key stakeholders are on board. We look at the progress that we have made up to date, and then it's also an opportunity for planning for the way forward and also sharing best practices. By way of improving health worker practice, we have used the information that we've gathered from the various surveys that I mentioned earlier, but also, in addition, we've done quality of care assessments in health facilities across the country. And we have made adjustments to some of our data sources, like our health management information system, where when we did a situation analysis, we realized that until then, we had been not disaggregating the data, so we were not seeing clearly what the newborn death rates were. Everything was lumped up under the infants, and so we've tried to disaggregate that. We've also tried to introduce indicators for following postnatal care. And we've also revised our child health registers to reflect similarly. And so all this helps us in planning for implementing our program. Under human resource, we had challenges with the numbers of midwives and other health workers who attend to newborns. And so since then, actions have been taken, some including expanding the facilities for training midwives and also adopting other courses like diploma courses for midwives and career progression for staff at the lower level to also take on some skills for newborn care. By way of in-service training, we've been improving skills through safe motherhood training, IMCI, which is now IMNCI, because we have adapted the IMCI training to include the first week of the newborn, and essential newborn care, ETAT, kangaroo mother care, and helping babies breathe. Helping babies breathe is also now currently part of our pre-service curriculum. The IMONG survey also brought out clearly the equipment gaps, the infrastructure gaps that we have across the facilities in the country. And this survey actually tackled almost all facilities, both public and private facilities. And so it is a rich source of data for our planning, and it's disaggregated to regional levels. So each region has its own data to look at to help them plan their specific programs. Under our policies and guidelines, we have adapted some, those that need to be revised. We have revised like the IMCI training materials, but we have also produced job aids to assist health workers. This we found was one of the main gaps in service delivery. And so job aids have been produced to assist with care for the newborn from birth, as well as for the sick newborn. And training has started with these materials, the job aids, in 5 out of our 10 regions. IMCI training is ongoing in all regions. Now to the community practices. Our policy allows community level actions to be taken by health workers. These are the community health officers, CHOs. These are regular nurses that are on government payroll, and they are placed close to communities and given responsibility over a number of communities in their zone. And their responsibilities are mainly to do with maternal and child health and newborn care. They conduct home visits on a regular basis. And so they are the closest health workers to the community, and they work closely with the communities, as well as volunteers. Now, volunteers include volunteers who are already existing for other health services, as well as TBAs. Much as we are not promoting the training of TBAs. We see their role in newborn care as very critical, and so we are trying to redefine their role and give them the role of ensuring that pregnant women deliver in health facilities, and also helping them with the newborn practices, breastfeeding, keeping the baby warm, and also identifying danger signs for early referral. Training has started already in 5 out of the 10 regions. And we have also revised our child health records, popularly known as our weighing cards. These are cards that mothers carry with them all the time. And so we have included messages on newborn care to ensure that they reach the lowest level to reach the homes and communities. There are radio programs that also are ongoing and tackle newborn care. In 2004, Ghana instituted Child Health Promotion Weeks, which we celebrate in May every year. And we have incorporated newborn issues. And in fact, 2 years ago, our main theme focused on the newborn. And we have been highlighting newborn issues during Child Health Promotion Weeks. This is a picture of a community health officer with a health committee at the village level discussing ways to improve health in the community. Now, what are our enabling factors? The fact that child and newborn health issues are a national priority have helped us to move this far. And the existence of a clear policy also has been very beneficial, so that anyone who comes on board has a reference material and knows where we are heading. The involvement of key stakeholders in the policy formulation has also helped us, because everybody sees themselves as on board and united in this venture. Our health system linkages with the communities is also one of the enabling factors. The fact that we already have health officers down at the community already working with volunteers gives us a ready environment to implement community actions for the newborn. And I must say that our partners are really supportive. The use of data has also been key and helped to move our agenda forward. Our challenges: we still have about 40% home deliveries, and nobody knows how these newborns die. And for those who come to the facilities, we are as yet not auditing newborn deaths, so that is a gap that we have to address. Quality of health services is also not up to scratch, and that is one area that we need to improve in terms of skills of health workers, as well as equipment and other facilities to work with. Inadequate human and financial resources is still a challenge, and we have harmful sociocultural beliefs and practices to contend with. The private sector, we've tried to involve them, but I must say that that linkage is weak, and is something that we also are working at. Sometimes there's fragmentation of implementation, in that there are several partners out there, and coordinating them all is one challenge that we are grappling with, but we are gradually making headway. Supervision, particularly for the community activities, is also another one of our challenges. And so as we look forward, these are the areas that we will be focusing on. Thank you.
Thank you very much. Thank you very much, Dr.